if you hear the word pneumonia, you probably picture a bad cough, right? Like a week of antibiotics, maybe a few days stuck in bed.
Yeah, people tend to think of it as just this one straightforward illness.
Exactly. A simple illness with a highly predictable fix. But if you think that, you would be entirely wrong.
Completely wrong, yeah.
Because what we are looking at today is a condition that is actually this complex, constantly shifting target. It's basically a microscopic crime scene that has, baffled and driven medical science for literally centuries.
I like to call it the ultimate medical chameleon. I mean, the way we define it, the way we classify it, and even the way we treat it at the bedside, it is still fiercely debated today.
It really is. So today we are taking this massive stack of sources. We've got nursing texts, historical accounts, medical journals, and our mission for this deep dive is to travel deep down into the microscopic air sacs of the lungs.
Right down to the cellular level.
Yep.
We're going to figure out the actual mechanics of pneumonia, why bedside assessments happen the way they do, and the critical nursing care that goes into fighting it. Joining me to help make sense of all this is our resident expert. And our goal today for you, the listener, is to get past rote memorization. We want to understand the actual why behind what a nurse sees at the bedside.
Right. The intention is to move way beyond just checking boxes on an assessment form. Because if you understand the underlying the actual physics and biology of what is happening inside those lungs, every single symptom makes sense.
Yeah.
Every crackle you hear through a stethoscope suddenly just has a perfectly logical explanation.
Okay, let's unpack this, because before we can talk about treating pneumonia, we have to understand the anatomy of where this is all going down,
Sure
right?
doing.
We are talking about an infection of the lung parenchyma, specifically the alveoli.
Yeah, so the alveoli are those microscopic air sacs at the very end of your respiratory tract. And their design is just beautifully simple, but it's also incredibly fragile.
They're super thin, right? Extremely thin. They are literally just one single cell layer thick.
Yeah.
And they are tightly wrapped in this dense net of capillaries. They're built for one specific purpose, which is gas exchange.
Right.
So oxygen diffuses across that paper-thin membrane into your blood, and carbon dioxide diffuses out to be exhaled.
But then, pneumonia enters the chat. And this is where we get a term that explains basically everything we're going to talk about today. Consolidation.
Yes, a hugely important concept.
Instead of being full of air, those tiny, delicate sacs fill up with inflammatory exudate. We're talking fluid, dead white blood cells, fibrin, microorganisms.
It becomes an active biological war zone in there.
To visualize this, I was thinking about it like this. Imagine healthy alveoli as a perfectly functioning soft sponge that just effortlessly soaks up air.
Okay, I like that.
Well, consolidation is like taking that delicate sponge and just pouring wet concrete straight into it.
Oh, wow.
It hardens, it fills all the gaps, and it becomes absolutely impossible for oxygen to pass through that barrier.
If we connect this to the bigger picture, that one microscopic block creates a massive system-wide crisis because, your heart doesn't know that part of the lung is filled with concrete.
Right, the heart's just doing its job.
Exactly. It keeps pumping blood past those blocked alveoli, totally expecting them to do their job and hand over the oxygen. And this creates a severe ventilation-perfusion mismatch. In the medical field, we often refer to it as shunt physiology.
So just so I have this straight, the blood is still perfusing the tissue, right? But there's zero ventilation happening because of the wet concrete.
You've got it. The blood passes right through without picking up a single drop of oxygen.
Jeez.
And then it circulates back into the body, completely oxygen depleted. So that simple mechanical failure explains the drop in oxygen saturation, the rapid breathing, and really that whole cascade of hypoxemia that a nurse assesses.
That makes so much sense.
That is the absolute core of it. The body is essentially suffocating on a cellular level, while blood flow just continues as if nothing is wrong.
Man, so we have this concrete forming deep, deep inside the body, wrapped safely behind a rib cage. Which brings up a really interesting historical question from the sources.
Yeah.
How did clinicians figure out how to detect this from the outside? I mean, Hippocrates actually named it way back around 400 BCE from the Greek word pneumon for lung.
Right, but the actual mechanics of it were just a total mystery for a very long time.
Right, so how did we crack it?
Well, it wasn't really until the early 19th century that things cracked open. In 1816, a French physician named René Laennec was examining a
The
patient.
stethoscope guy, right?
Exactly. He felt it was improper to place his ear directly on this female patient's chest, which was the standard practice at the time. So he rolled up a piece of paper into a cylinder, which eventually became a wooden tube. and that was the very first stethoscope.
That's amazing.
But Lenonic didn't just casually listen. He spent years meticulously correlating the specific crackling sounds he heard, what we call RELs, with what he actually found when he performed autopsies on those exact same patients after they died.
So he literally connected the sound of the crackles directly to the fluid-filled alveoli.
He did.
He basically gave us the acoustic signature of that wet concrete.
That's a great way to put it. He systematically linked a sound you can hear on the outside to a very specific pathological lesion on the inside. And honestly, it's the reason nurses today still listen for those exact same crackles.
Because it's the sound of the alveoli popping.
Yes. When the sticky walls of the alveoli are forced to pop open during inspiration, that acoustic energy travels right up the stethoscope.
And people really needed to listen for it, too, because back then, pneumonia was just devastating. Looking at the historical texts, in 1901, the legendary physician Sir William Osler borrowed a phrase originally used for tuberculosis.
Yes.
He called pneumonia the captain of the men of death.
It's an incredibly chilling title,
Mm.
but highly accurate for the time. Before antibiotics, pneumococcal pneumonia had a mortality rate of around 30%.
30%, that is terrifying.
Osler was really sounding a clinical alarm bell. He wanted his medical students to realize that this was not some routine mild illness. It was an aggressive, fast-moving killer.
And the history of discovering the actual bacteria behind it is fascinating. There was this massive scientific rivalry in the late 1800s over what was actually causing it.
Oh yeah, the microbiology race.
Yeah. In 1882, Carl Friedlander found a bacterium in patient sputum and basically declared he'd found the culprit. We know it now as Klebsiella pneumonia.
Right.
But then you have Albert Frankel and Louis Pasteur, and they keep finding a completely different bacterium, Streptococcus pneumonia.
The famous pneumococcus. The main problem was, under the microscopes of the 1880s, these two different bugs looked incredibly similar.
Yeah, we're just tiny dots, right?
Pretty much. They were both small, roundish bacteria. It was an absolute diagnostic nightmare to tell them apart.
Okay, wait, let me make sure I'm understanding this, because I read this in the notes and I wanted to clarify. Did Hans Christian Gram literally invent the Gram stain in 1884 solely to settle this one specific pneumonia debate?
He actually did.
No way! That's crazy.
Gram developed his whole staining technique for the express purpose of distinguishing the Gram-positive pneumococcus, which, held the purple dye,
Huh?
from the Gram-negative Klebsiella, which lost the dye and turned pink.
Wow.
It was invented entirely to solve that one specific diagnostic rivalry. And today, essentially every single microbiology lab on Earth uses that exact same mechanism to categorize almost every known bacterium.
That is wild. A foundational tool of modern medicine was born just to figure out which bug was building the concrete in the lungs.
Necessity is the mother of invention.
So, armed with stethoscopes and Gram stains, how do modern nurses actually track this captain of death at the bedside? Because the texts emphasize that classic symptoms can sometimes be completely misleading.
They really can. To understand what a nurse sees, you first have to look at the natural arc of the disease. Pathologists who studied lobar pneumonia before we had antibiotics documented 4 strikingly predictable stages of the illness.
Which surprised me. I always assumed pneumonia just, slowly got worse and then eventually slowly got better. But the sources outline this highly specific, almost robotic 4-stage cycle.
Very regimented.
So what is actually happening in the tissue during that first 48 hours?
Well, that first stage is called congestion. This is usually days 1 to 2. The pathogen takes hold, and the local capillaries engorge with blood.
Wow.
The alveoli start filling with this thin, bacteria-laden fluid.
Okay.
And this is when the nurse first starts hearing those classic crackles on auscultation, as the air really struggles through that mounting fluid.
Got it. And then stage 2 is red hepatization. That's around days 2 to 3. And I have to say, this part is gruesome, but the physical changes are intense.
It is intense. The alveoli get so densely packed with red blood cells, neutrophils, and fibrin that the lung tissue physically transforms. If you were to look at it pathologically, it actually looks and feels exactly like a liver.
Which is what hepatization means, right? Liver-like.
Exactly. Hepatization.
And because solid tissue transmits sound differently than airy tissue, this is exactly when a nurse will percuss the chest, tapping on it, and they'll hear a dull thud instead of the hollow resonance of healthy lungs.
That's exactly right.
It's also when bronchial breath sounds become prominent in the outer lung fields where they really shouldn't be, because that solid liver-like tissue just conducts the harsh sound from the windpipe straight out to the chest wall.
You've nailed the physics of it. Then we move into stage 3, which is gray hepatization. This is typically days 4 to 6.
So why does it turn gray? Does the blood just go away?
Sort of. The red blood cells that flooded the area start to break down and degrade. So they leave behind this really dense network of fibrin and white blood cells, which turns the lung a sort of gray-brown color.
Gross.
Yeah, the pressure inside the alveoli is immense at this point, and the tissue is just completely consolidated, solid concrete.
And finally, stage 4, resolution.
Right. This is when enzymes start digesting the exudate and macrophages swoop in to clear out all the debris.
And historically, if a patient survived this long without antibiotics, they would hit what Osler called the crisis, right?
Yes, the famous crisis. It was this sudden, really dramatic drop in fever and rapid symptom improvement, sometimes happening within hours.
Just boom, they get better.
Yeah. We rarely see it today because antibiotics interrupt the cycle early. But it proves that the disease has a natural, self-limited arc if the immune system can just hold out long enough.
So bedside nursing assessments basically have to track that arc?
Because we do. They do serial vital signs. And it's really worth noting here, respiratory rate changes are often the very first early warning sign, even before the oxygen actually drops.
Oh, really? Just breathing faster?
Yep. They watch pulse ox trends, they auscultate for sounds, and they percuss for that dullness we mentioned. They're also checking for egophony.
Let's explain egophony, because when I read about it, it sounds like a parlor trick, but it's pure physics.
It totally is.
If a nurse puts a stethoscope on a patient's chest and asks them to say the letter E, healthy lungs will transmit an E sound. But if there is fluid or concrete in the lungs, the sound waves get distorted. So that E actually sounds like an A through the stethoscope.
Spot on. It's an E to A change. They also check for increased tactile fremitus. This is where the vibrations of the patient's voice literally feel stronger against the nurse's hands when they touch the chest wall.
Because solid concrete conducts those vibrations much better than empty air.
Exactly. But nurses also have to differentiate all of this from neighboring conditions, which can be tricky.
Like bronchitis.
Right. Bronchitis is inflammation of the airways, the bronchi. So it causes a nasty cough, sure. But the alveoli will remain completely clear. There's no true consolidation.
Okay. What about atelectasis? I always get that confused.
Atelectasis is just alveolar collapse. Think of it like a deflated balloon. It's often seen after surgery when patients just aren't breathing deeply because of pain.
Oh, so they just kind of shrink down.
Right. It can mimic pneumonia with dullness to percussion, but you won't see the fever or severe infectious markers.
And then there's pleural effusion. That's when fluid builds up around the lung in the pleural space, right?
Yeah.
Not inside the alveoli.
Exactly. Outside the lung itself.
And if that happens, the liquid actually blocks sound from reaching the chest wall. So a nurse will feel decreased fremitus and hear absent breath sounds.
Yeah.
It's basically the opposite of consolidation.
Knowing those physical mechanics allows you to distinguish between a lung filled from the inside versus a lung compressed from the outside.
Okay, let's talk about x-rays, because this is where the delayed photograph analogy really helped me out. I always just sort of assumed an x-ray was the ultimate unquestionable proof.
A lot of people think that.
But the texts point out that an x-ray can be completely clear early on, or even in a severely dehydrated patient, even when they are incredibly sick. It's kind of like taking a picture with an old Polaroid camera.
Oh, I like that.
The reality is happening right now, but the visual evidence takes time to develop on the film.
That is a highly accurate way to look at it. The radiographic consolidation, the white shadow on the x-ray, it can lag behind the clinical disease by a day or two easily.
Wow.
Furthermore, if a patient is dehydrated, they literally don't have enough fluid in their body to produce the exudate that shows up on the film in the first place.
That makes total sense. No fluid, no shadow.
Right. So if a clinician looks at a clear x-ray on day 1 and completely rules out pneumonia, they might be making a fatal error.
We also have to debunk some major misconceptions here, like sputum color. A lot of people think that green or yellow mucus automatically means a bacterial infection that absolutely requires antibiotics.
Oh, that's a huge myth. Color just reflects the presence of white blood cells.
Huh.
Specifically neutrophils, which release an enzyme called myeloperoxidase.
Okay.
And that enzyme contains a green heme pigment. So if you have neutrophils fighting any infection, your mucus will be green or yellow.
But viruses trigger neutrophils too, right?
They absolutely do. Viral pneumonias trigger them just like bacterial ones. So sputum color is simply not a reliable way to differentiate bacterial from viral pneumonia.
Okay, another one. Walking pneumonia. People treat it like a mild kind of fake illness.
Yeah, they really do.
But Mycoplasma pneumonia is a real, highly infectious bug that causes a true alveolar infection. The patient just happens to feel well enough to walk around spreading it.
Unfortunately for everyone else, yes.
But what really stood out to me in these sources is the danger of relying on classic signs, especially in older adults.
Yes. The classic triad we are traditionally taught is fever, productive cough, and pleuritic chest pain, which is pain when you breathe in. But as we age, our immune system mounts a much more blunted response.
So you might not even see a fever.
You might not see a fever at all in an elderly patient. The very first sign of severe pneumonia might just be sudden confusion, generalized weakness, or even a fall.
Just a fall.
Just a fall. If you only look for the classic triad, you will miss the diagnosis completely in that population.
And we saw a modern version of deceptive symptoms with COVID-19, didn't we? The whole silent hypoxemia phenomenon.
Yeah, in early 2020, clinicians were just baffled. They had patients sitting up in bed, talking calmly, scrolling on their phones. They were showing zero visible signs of respiratory distress.
No gasping or anything.
No gasping, no struggling, but their oxygen saturations were in the 80s or even lower.
It's just terrifying.
Normally, numbers that low trigger sheer panic and air hunger. It proved that visual signs of distress, which nurses are heavily trained to watch for, can completely fail depending on the pathogen.
Right.
It permanently reinforced why we must rely on numeric, continuous pulse oximetry trends rather than just the visual look of the patient.
Assessment is incredibly tricky, but figuring out exactly what kind of pneumonia we're dealing with and how to treat it is honestly even harder. And it's led to some massive historical missteps.
Oh, definitely.
Like, we used to classify pneumonia anatomically based on lobes versus bronchi.
We did, but modern imaging and antibiotics really blurred those anatomical lines. So today, the classification we use is epidemiologic. We categorize it by where you actually caught it.
Right, geography.
Yep. So you have community-acquired pneumonia, or CAP, hospital-acquired pneumonia, which is AJP, and ventilator-associated pneumonia, VAP.
And that matters because the geography basically acts as a predictive model for what bugs we're fighting. A healthy 30-year-old who gets sick after riding the subway has CAP.
Right.
And they need very different antibiotics than a patient who's been on a ventilator for 5 days and has VAP, where the bacteria are often highly drug-resistant.
Exactly.
But that brings us to the HCAP label, healthcare-associated pneumonia. This really highlights our tendency to just panic prescribe. Let's talk about why that failed so spectacularly.
It was a big deal. So in 2005, guidelines introduced HCAP for patients who weren't actually hospitalized but had risk factors, like nursing home residents or people on hemodialysis. The assumption was, well, because they interact with healthcare environments, they must be harboring dangerous, drug-resistant hospital bugs.
Makes sense on paper.
It does. So the guidelines told everyone to hit them hard with broad-spectrum antibiotics right out of the gate.
Powerful drugs like vancomycin, just as a precaution.
But later studies revealed an absolute disaster. The HCAP criteria swept up vast numbers of patients who did not actually have resistant organisms. We were massively overtreating them.
And that's bad because
Broad-spectrum antibiotics are not harmless. They wipe out your natural gut flora, which can lead to life-threatening C. diff infections. They cause severe drug toxicity. And, of course, they drive global antibiotic resistance.
So we were creating superbugs for no reason.
Exactly. The category was such a failure that the 2016 guidelines completely eliminated it.
Just wiped it off the map. That fear of undertreating is driving another massive debate today, too. How long those antibiotic courses actually need to be. Doctors love prescribing 10 to 14 days of antibiotics. It feels safe.
It's tradition at this point.
But modern trials, like the Uranga study in 2016, prove that if a patient is clinically stable, 5 days is often completely sufficient. Treating longer doesn't actually help the patient. It just drives more resistance.
And there is an even harder judgment called nurses face daily, which is the aspiration dilemma.
Oh, this sounded so difficult to deal with.
It is. If a patient accidentally inhales stomach contents, they might develop aspiration pneumonitis. That is a chemical burn from the gastric acid.
Right.
It causes massive inflammation and honestly looks exactly like pneumonia on an X-ray.
Right.
But it is not a bacterial infection.
Well, no antibiotics needed.
It does not need antibiotics.
However, if they inhale bacteria from their mouth or throat, that's aspiration pneumonia. And that does need antibiotics. Distinguishing between a chemical burn and a bacterial infection at the bedside just seems incredibly difficult.
One of the hardest things we do.
But getting it wrong means throwing drugs at a problem they cannot fix.
Exactly.
Here's where it gets really interesting. Because throwing antibiotics at the wrong problem is a huge theme here. Let's look at viral pneumonia. Antibiotics do absolutely nothing for a virus.
Nothing at all.
But the history of viral pandemics shows us how intertwined they are. Look at the 1918 influenza pandemic. Over 50 million people died. But a 2008 analysis by Morens, Taubenberger, and Fauci, looking at preserved autopsy tissue decades later, found something absolutely staggering.
It really reframed everything we thought we knew. They found that the vast majority of those deaths were not directly caused by the influenza virus itself.
Wait, really?
Really. The virus came through, ravaged the delicate lining of the lungs, and basically kicked the door wide open. But what actually killed the patients was secondary bacterial pneumonia, streptococcus, staphylococcus, Haemophilus. They invaded those virus-damaged lungs.
So the virus opened the door, but the bacteria brought the concrete.
I love that analogy, yes, and this raises an important question. In our modern era, how often are we blindly throwing antibiotics at uncomplicated viral infections out of fear versus appropriately monitoring for that secondary bacterial wave?
It's a tough balance.
It requires incredible clinical restraint and skill to withhold antibiotics when a patient is sick with a virus, but it's absolutely essential for preventing resistance while still catching the secondary infection if it actually arrives.
So what does this all mean? Pulling this all together, what is the ultimate impact on the patient and the healthcare system? Because pneumonia isn't just an isolated lung problem.
No, not at all. It is the single most common infectious trigger for sepsis. Every time a nurse assesses a pneumonia patient, they have to simultaneously be running a mental sepsis screen.
Looking for what exactly?
Looking for systemic inflammation and organ dysfunction. And if the inflammation overwhelms both lungs bilaterally, you end up with ARDS.
Acute respiratory distress syndrome.
Exactly. Which is profound, very often fatal hypoxemia.
It's a leading cause of death globally, especially for the very young and the elderly. And in the U.S., it drives major hospital quality metrics. Hospitals get financially penalized for readmissions.
Getting this right is paramount. And the bedside nursing actions are truly the front line of this defense.
Right, like getting sputum cultures before that first dose of antibiotics is given, so we actually know what bug we are fighting instead of just guessing.
Absolutely. And it means mechanical interventions, too. Positioning the patient to maximize ventilation. Elevating the head of the bed so gravity can pull the diaphragm down and let the lungs fully expand.
And using an incentive spirometer, I read that it isn't just about breathing deeply. The positive pressure from the spirometer literally forces air behind the mucus, so it pops open those sticky, collapsing alveoli before they can turn into concrete.
It's essentially mechanical ventilation on a small scale.
And education is just as vital, right?
Oh, massively. Promoting pneumococcal and flu vaccines to prevent the cascade in the first place.
Right.
Counseling on smoking cessation to preserve the cilia that sweep mucus out of the lungs.
And enforcing aspiration precautions for patients with swallowing issues.
Right. These actions literally save lives by preventing the concrete from forming to begin with.
But as we look to the future, I know you had a thought about where this whole classification system is heading. We talked earlier about how we currently classify pneumonia based on geography, hospital-acquired versus community-acquired.
Yeah.
But today, healthcare is changing incredibly fast. With the explosion of telehealth and hospital-at-home programs, you have patients receiving ICU-level care, IV antibiotics, and complex monitoring right in their own living rooms.
It's a massive shift. So if a patient develops pneumonia while receiving hospital-level care in their own home, is that community-acquired or hospital-acquired?
Wow, that's a really good question.
Will our strict epidemiological labels completely collapse? We might be forced to invent an entirely new way to predict which bacteria are lurking in the alveoli, because the geography of where care happens is no longer black and white.
The chameleon keeps changing colors. It just goes to show, the next time someone tells you they have pneumonia, remember, it is never just a simple diagnosis. It's an active battle over a microscopic sponge, and keeping the concrete out is one of the greatest, most enduring challenges in medicine. Thanks for diving deep with us today. Keep asking questions, and we'll see you on the next one.